Hi, I'm Dr. Mark Goetting, and you can see the title of the talk. This is on a difficult topic, and that is providing sleep health to children with developmental disabilities. Let me push forward. I have no conflicts of interest to disclose. Let me begin with the principles of taking care of these patients. There are a few, and I think you'll find they're sensible. The first is that developmentally disabled patients are subject to the same sleep disorders that all other patients are. So that could be sleep apnea, restless leg syndrome, chronic insomnia. In other words, having a developmental disability doesn't exempt them from the common sleep disorders that we see in children who are not subject to developmental problems. The second is that these patients may tolerate common sleep disorders less well because of their conditions, physical, cognitive, emotional, and family factors that can be attributed to their developmental condition. So to this point, a recent study looked at what happens when sleep deprivation occurs to people who have ADHD, a developmental issue. What it shows is that their cognitive capabilities are more susceptible to sleep deprivation, the same degree of sleep deprivation as those that do not have a developmental disability, specifically ADHD. The point is that these kids need to have extra protection to ensure that their sleep is adequate, because the consequences can be more dramatic for them. Third principle is that there are specific sleep disorders associated with specific underlying conditions. In some cases, not all. So for example, a disorder called Smith-Magenis syndrome, there is a profound circadian shift in them, where they tend to be awake at night and sleep during the day. Kids with Down syndrome are prone to different sleep disorders, which I'll touch on in a moment. Common sleep disorders may be best treated by different approaches in specific conditions. So taking into consideration what the developmental issues are with a patient may help to customize or form therapy that is more appropriate to them. The treatment of the underlying condition may worsen sleep. So I'll give you a common example: anxiety and depression. Treatment with medications for that, even though I won't call them developmental disabilities, can predispose to restless leg syndrome, restless sleep disorder, and sometimes insomnia. So the treatment itself may introduce in some kids sleep disorders. Most of these patients and their families do respond to established or routine sleep management for problems. So those ought to be initiated first before looking at unique approaches to a child with a developmental disability. And lastly, sleep disorder treatment requires recognition of the strengths and limitations of the unique patient, the patient's family, and social resources. I'll get into that. Also, there's an old cover of Newsweek magazine that has not been surpassed, in my opinion, for expressing frustration with a sleepless child. And what we can see is, here is the mother, the baby's crying, the clock says 3 o'clock, and somehow the husband is able to sleep through this. So sometimes when we approach children with really difficult sleep disorders who perhaps have developmental disabilities, we have to prioritize our goals. The first goal is what I would call nutritive or restorative sleep, which is the goal for all children. That is to put the child into the best situation for learning and modulation of emotions and socialization. If we can't achieve that very well, we do work for a restful period for the parents, and that is that there's some amount of sleep that allows the parents to get rest as well, even if the child has some interruption in sleep, or maybe will have to compensate for sleeplessness during the night with naps, but enough sleep for the parents too. And then lastly, we want a functional family. And sometimes that involves other things, including respite for the family, where the child may end up staying with a relative for every other weekend or something, just to keep the rest of the family functioning well. So snoring is obnoxious, but I'm not sure snoring is any worse than this. A sleepless child is a stressful situation for the family. It primarily tends to affect the parents, and I have to be honest, my experience, primarily it's the mothers who end up taking care of the sleepless child more so than others. But it also indirectly affects siblings. So if you have a child with developmental disabilities that has particular needs during the day and is sleeping poorly at night, that child will take away care from the parents towards the healthy child. So instead of 50% of the parental attention being given to one child versus the other, it may be 75, 80, 85% or so. The parents often will remark that they feel bad about that situation. They feel like they can't do all that they want to do for the other children, and they have guilt. The siblings can have resentment about that, but they also will often, as will the parents, feel a bit of shame having resentment, because they will feel that this child who has a developmental disability isn't doing that on purpose, isn't acting out just for attention, but really has a serious problem. And that maybe they're being selfish, expecting to be relieved from the obligations caring for that child. So in approaching a child who has sleeplessness or insomnia, it's important to have realistic expectations. And this is particularly true in kids who have developmental disabilities and sleeplessness. So first of all, the family, the child and the caregiver have arrived at some point. It's not satisfactory, but they have a bit of an equilibrium as to how they work out this problem. Neither side may be fully happy with it, but they've arrived at the point where they've arrived, and there is often some investment in that, meaning there's some inertia, some reluctance to try to stray from that, because where they are is where they've ended up after many different trials, and they may not want to try something different for fear that it will undo any bit of good that they have done. I hope that's clear. The second is that often in a sleepless child, there are several causes for it, not just one. So it may be that someone has a low iron level and you boost the iron, and that's now normal, and they're still not sleeping that well. Don't be surprised. There could be other things going on. So always be suspicious that there's yet another factor. And the third is that relapse is common. There can be an initial favorable response to therapy, and then things start to fall apart for any number of reasons. For example, if what is common is that there's a lot of effort put into stabilizing sleep with a hope that once it's stable, they can just back off all that effort and things will remain improved, and they often don't. So let's keep that in mind. So in life, though, the success rate is pretty good. Let me give you some sports analysis figures. So if we look at some of the best free throw shooters in the NBA, we can see that there are failures fairly common. So it may be 1 out of 10, it may be 2 out of 10 professional basketball players who miss free throws. So not every intervention we do to improve something more complicated, and that is a sleeplessness state in a developmentally disabled child. We shouldn't expect that we're not going to have failures. But let's look at baseball where it's worse. And at the top here is our own Ty Cobb, long time ago, but one of the best hitters of all times. And it's about 2/3 of the time he did not get on base. So persistence. Let me give you some examples now of patients. Here's a 2-year-old with frequent wakings. So I want you to imagine if you're in a sleep center or you're in an office, a medical office, what comes to mind when you hear that? My child gets up repeatedly during the night and interferes with my sleep, and I've tried everything. So you probably have a picture, but now let's put it in a different context. What if the 2-year-old is this girl who's living in shelters and to another home, back to a different shelter? You know, it's much more complex, and it'd be completely expected that sleeplessness will be refractory because sleep requires a sense of safety and predictability in children. And when the sleep environment is switched, it is normal, even helpful, to wake up to make sure that there's safety in the environment. One of the important aspects of sleep is to enhance learning. So learning isn't just one thing. We learn behavior, social interactions. Some of us learn it from TV, some learn it from our family, some learn it at school, but we watch others and we get a sense as to what we should do and what will happen if we screw it up. Certain skills, sports would be an example. There's a variety of skills. Learning is necessary for that. Fundamental knowledge, knowledge about the world, general education, another form of learning. Self-insight as to how you think about the world and how you see yourself. And then mood, appropriate mood for an action or an environment, a situation. All of these things have an element of learning, and sleep is absolutely essential to every one of those to carry on efficiently. Sleeplessness worsens those things. So here is just a reference of an earlier study, the first I could find, where objectively having an episode of sleep in between trying to memorize something and then reciting what you memorized showed that sleep was beneficial in solidifying or consolidating memory. Now, slow wave sleep appears to be very important for this, maybe disproportionately to other forms of sleep. And so one question was, well, what if we electrically pace the brain during sleep so that we can have more slow wave sleep by putting electrodes on the skull and pushing that electricity through the skull? So who would you find to do this on? Well, this was done in Germany, and of course they use medical students who will do almost anything. What it did show is that when the students had their brain paced, so they had more slow wave sleep artificially induced, they did learn better. They did have more memory. And what we've found more recently, and this is the second bullet point of the highlights, is certain things in the room that create a soothing sound or an appropriate smell, a good smell, will also enhance learning. But what is disruptive? Well, chaos is, because chaos is something that will cause sleep to be shallow and fragmented. Chaos involves a lack of predictability and control over the environment, which causes an arousal in us that will make sleep more fragmented and superficial and diminish slow wave sleep. So it interferes with learning. So the second thing my bullet point may seem odd to you, the mixture of love and pain. Now, I'm not going to go in the direction you may be thinking, but imagine a child is frequently hospitalized with cystic fibrosis or some other condition, spasticity with cerebral palsy and kyphoscoliosis and recurrent pneumonia, for example. When they get hospitalized, often what they will do when they fall asleep is wake up to someone drawing their blood, and the same person who may be there while blood is being drawn, whether it is medical staff such as a nurse or the parents, are those same people who act to them loving all the time and smile and soothe and reassure and comfort, but suddenly they now have a needle or they're holding an arm so that a needle can be put into them. So this is a form of chaos with pain mixed in with that is common in kids who have significant disabilities. Just something to keep in mind, that if we can improve predictability by somehow letting them know when something painful is going to happen, or a simple intervention is to wear something that they can see and understand that is going to be linked with something unpleasant. So, for example, put on a green gown every time you go in the room, and that's when blood's going to be drawn, but wear yellow all the other time. Something simple like that can be helpful in consolidating sleep better. Okay, let me talk a little bit about some comments from people who have autism and have had some issues with sensory abnormalities. So Temple Grandin is probably the most famous person, and she's pictured here, and she loves horses, and she's kind of the inspiration for weighted blankets, but she describes this, and I'll read it. I discovered that I could shut out painful sounds by engaging in rhythmic, stereotypical autistic behavior. Small itches and scratches that most people ignored were torture. It took several days for me to stop feeling a new type of clothing on my body. So she's able to articulate this. Many people with autism cannot. And so this could be a completely different perception of the world in which there is pain or offense or discontent in some way by things in the environment that we can't really appreciate, and that will affect sleep. Here is another lady who has written about her experience with autism, and it's specifically on sleep. I was afraid to sleep, always had been. I would sleep with my eyes open. Haunting or haunted would have been better adjectives. I was afraid of the dark. So while we may hear nothing, she might hear something like this.
I'll get you, my pretty, and your little dog, too.
I exaggerate a little, but you get the point. So kids with autism are particularly prone to issues with sleeplessness and may require more experimentation in that which is helpful for them to enter into sleep and stay into sleep. Melatonin has been very useful for many kids who have autism. So let me switch to a broader group of people. So insomnia in children has been defined as repeated difficulty with sleep initiation, duration, consolidation, or quality that occurs despite age-appropriate time and opportunity for sleep and results in daytime function impairment for the child and or the family. Now, at the time that this definition was put together, most people did not believe that children had insomnia. There was a saying that adults can't get to sleep and children won't get to sleep. But truly there is insomnia in kids, and particularly in kids with developmental disabilities. So how do we assess them? We do a general history about medical and social issues, review their medications and any other kind of therapy they may be using, and then do what I call a circadian history, but it's a 24-hour history. When do you get up in the morning? What is that like? How do you feel? Or if the person can't verbalize, how does the child behave? How long does it take to achieve alertness? What about meals? What about naps? Where are naps most successful? Where are they least successful? Can you predict, whether a child will nap or not? And then the bedtime winding down, the sleep environment, etc. So you go around the whole clock, and occasionally you find something that is really radically important. An assessment of the home and social environment, like who's available for caregiving, who provides most of the caregiving, how is that done? Another point is to discuss expectations for sleep. Some parents would like their child to sleep 12, 14 hours or so when that's not going to be reasonable, particularly if you're talking about an older child. And then review the laboratory testing that's been done, because occasionally we find thyroid dysfunction or low iron levels or other things that may interfere with the ability to sleep adequately. One of the objective measures, that is commonly available is actigraphy. So this is an actigram on a 59-year-old, and you're probably familiar. So it looks at wrist motion. Wrist motion in certain patterns is equated with being awake. Now that's not 100% true all the time, but it's usually true. And that sleep is associated with less wrist activity. That's the idea. And instead of looking at this at one night, we look at it for weeks. So we get big picture information. What we see in this particular one is I'm just going to set this up for you. So the white should be during the day, and we have 2 days here. And what we would expect is activity is most during the day. So this begins at 1 o'clock when the person put the device on. And somewhere around 11 or so, 10:30, the activity trailed off. Probably the person went to sleep. So, you can look at this and get a sense that this person is relatively boring. On some days the person sleeps in longer. Like Saturday, the guy slept in a little longer. Sunday, but then had to get up for work. All these other days. All right. So that's an example of showing consistency in their sleep-wake pattern for the most part. But children can be predisposed to circadian rhythm disorders and circadian rhythm changes that aren't really disorders. So evolutionary biologists would say, well, children need to sleep partly because they need to be quiet during the night, and they need to have some respite time for the parents to do whatever they're going to do. Now, others will argue, and they're right, that a lot of neurobiology occurs during sleep that's critical. But if you take that away, you can understand why it would be important for an infant to sleep during the night. If you're out in the jungle and it's dark in the middle of the night, crying is an invitation for predators. So not good. So there is normally a contraction, a shortening of the amount of sleep a child will optimally get with age. And there's also a delay in the time the child will go to sleep. So as they get older, they tend to stay up later. But beyond those normal changes, there can be unsatisfactory or harmful or maladjusting changes in the circadian rhythm. And the two of the common ones are delayed and advanced sleep phase syndrome. So as you probably know, delayed sleep phase syndrome would be an unhelpful delay to routine onset of the circadian propensity for sleep. So what that might look like in a 15-year-old is having great difficulty falling asleep before 1 a.m. or maybe, midnight. Advanced sleep phase syndrome might be the person who wakes up too early at 4:30 or so, and is wide awake and wonders why no one will get up and do things with them. Or is the boring person who becomes sleepy at 9 p.m. and no one wants to date because of that. So there are some sleep variants in the population. Some people require more sleep, some require less sleep for the same sort of natural balance in neurological functioning. And there are many adults, 30 or 40%, and I get this is about kids, that have middle of the night wakings, which we treat as if it's an ailment or a disease, but it is really a normal variant, typically between 1 and 3 a.m. It's so common that there are 2 prescription medications specifically for that awakening pattern. The last thing I want to mention is social jet lag. So social jet lag really has nothing to do with your internal biological rhythm, but it has to do more with the work week or school week. So what that means is that typically Friday night, people stay up later and then they sleep in Saturday morning. And the same with Saturday night, Saturday morning. And then so Sunday night, they may not be tired at the same time, particularly with teenagers. and it's much more difficult to get up in the morning in time for school. So we can call that social jet lag because it's not really due to circadian rhythm per se. It's a behavioral pattern. So the interventions that we have are as listed. So treating an underlying disorder might be restless legs, or it might be sleep apnea. We can look at sleep hygiene. In children, that tends to be more important than it is in adults in ensuring a good bedtime and adequate continuity of sleep. And I'll talk a little bit about one form of cognitive therapy, but cognitive therapy is basically trying to address harmful beliefs and replace them with truths, but they're a little more helpful than the pessimistic ones that they may have, or the anxiety-provoking one. Children are affected by a winding down routine. So a winding down routine would be kind of similar to an airplane landing, that it should be pretty much the same every time. There's a routine set of things that occur that happen in that process. And as they happen, it also prepares the brain for sleep. So it might be, you know, a certain activity with a family and a child, brushing the teeth, getting the pajamas on, quiet time for a little while, maybe a story, and then in bed. And the more that's reinforced, the more successful it can be. Positive ideation can be helpful for those who tend to have a negative attitude. And that is that it's comfortable to be in bed, you're safe in bed, this is your time to think about the day and plan for tomorrow. So the bedroom needs to be safe. We need to, excuse me a second, we need to be aware of the possibility of medication intervention in some children who need it. And as I mentioned before, some families do need respite for the profoundly sleepless child who disrupts the homeostasis of the family. So I want to make a little point here by showing you this reference. So this reference involves a study of kids with ADHD, those who have some other psychiatric issues, and then those who are healthy. So the parents needed to assess in these kids, how long does it take to fall asleep? So how difficult is it, but in terms of time? And they also wore actigraphy so that there can be some objective measure as to how long it took to quiet the child down to bed. So the interesting thing is that it felt like it took a lot longer with kids with ADHD. So in fact, it did take longer. It took about 13 minutes longer on average for a child with ADHD to fall asleep. But I'm sorry, 5 minutes, no, 13 minutes. But it seemed like a lot longer, which suggests that there was a bit more of a struggle or is more taxing to the parents, even though the amount of time spent there wasn't dramatic. It just felt like more. So some things that can be helpful for kids who have difficulty falling asleep, particularly those with developmental disabilities, in order to provide some stability in the environment, to drown out excessive noise that may come and go and doesn't have a predictable pattern, would be these things listed. A sound machine isn't always helpful, but in some people it makes a difference. It could be rain, it could be waves, it could be wind, but it helps to minimize the random household noises like people walking by, boards creaking, doors open and closing. A fish tank can form a source of light with a little bit of activity that may be engaging, but not that exciting as to delay onset of sleep. Some people will use a computer screen with a background of an aquarium. There are other things that can be done to help create a soothing environment. Usually you don't want other pets because other pets have a mind of their own, and they may be more distracting than they are soothing. There's some exceptions, of course. So I talked about cognitive interventions. The main one would be regarding worries. So there are different ways to work on worry. So one is to have what some would call worry time. So in your evening routine, maybe you spend 5 minutes with a child talking about what are you concerned about and finding a way to reassure them. And then the worry time is over. There are books that you can get to go through writing out and examining worries that are age appropriate for children that can help with that. And then some people use a worry box, and that is that they discuss their worries, they're written down on a little card, and when they've talked through it and they're done with that worry, they put it in the box and close the lid and maybe even put a lock on it. So there are behavioral interventions and drug treatment for sleeplessness. And there's pros and cons for both. So the behavioral intervention, my particular concern about it was that these pleasant, caring, very nurturing parents during the day will suddenly put a 15-month-old or 20-month-old in bed, close the door, and no matter how that infant or child screams, they won't come in. So there would be a sense of abandonment, certainly a bit of animosity from the child. We sometimes say, well, we're teaching the child to sleep, but we're not really. We're making develop self-soothing activities. But I always had wondered, well, what happens down the line to this kind of programmed abandonment that occurs when you use the kind of the classic put them in the room, let them cry it out happen. And we have some reassuring information that somewhere around the first grade, kids who have been through that seem as well adjusted as the other kids. So that's good. There's many different variants as to how to be, I think, humane and still be strict about encouraging sleep and self-soothing behavior. So the downside with drugs is there's side effects, there's dangers. Instead of giving the message to the child that your sleep problems can be controlled within the family, we use a disease model. We don't ask the child for permission to give them a drug. The parents make that decision, so the child doesn't assent to it. But it can be helpful. It's usually a second choice under certain circumstances in which the risk versus benefit balance is favorable. So quite a while ago, I was a member of a committee who and it, ended up defining sleepless children as those having insomnia and reviewing medication therapy. So this is a long time ago, 2005. We have made a fair amount of progress, a lot of progress since then. So this is much of our arsenal right now. Diphenhydramine or Benadryl can be useful in some children, but commonly they develop tolerance to it. Clonidine is one of our commonly used tools in developmentally disabled kids with refractory insomnia. Melatonin has been shown to be useful in children with ADHD as well as autism, and perhaps some other situations as well. There have been, an increased amount of use of melatonin. It's gone up, something like 500% in the last decade or so in the number of children using it. And the blood levels of melatonin we give it by mouth are tenfold higher than the natural melatonin levels, up to 100 or more fold. So there should be some thought to that, to use the lowest dose that's effective. GABA agonists would include Ambien and maybe Klonopin. Ambien has not been very successful in children, and they metabolize it very quickly. Klonopin has its downsides too, because of sedation without falling asleep. Is a controlled substance. Trazodone has kind of a medium amount of use in children. Gabapentin has been helpful for kids with autism. There's pretty good data on that. And also kids with restless sleep disorders and restless leg syndrome. So let me give you a couple of cases. This is an 8-year-old girl with Down syndrome who had frequent wakings, and she would appear to be in pain when she awakened. She'd only snore intermittently and mildly. She did have excessive sleepiness. Let me see if, yeah. So if you look at her back, you'll see she's breathing. She's not snoring. She's breathing very gently. But look at her posture. Here's her one knee. Here's another leg. Kids with Down syndrome have decreased muscle tone, and they can sleep in various postures. But this one suggests obstructive sleep apnea, leaning forward to move the tongue out of the way, allow the jaw to go forward. And she did have obstructive sleep apnea. The painful wakings were due to hip pain. And if you try to sleep that way, I will bet you'll have some hip pain. Here is a different patient, a 16-year-old with bipolar disorder and ADHD. Over the last 6 months, she's developed insomnia, difficulty maintaining wakefulness during the day, and school failure. So here is her actigraphy. Compared to the first one I showed you of that 50-some-year-old guy, what you can see is that sometimes she is up. So this is around maybe 11 in the morning, she gets up, and it looks like she naps here. She's up in the middle of the night till 3 in the morning. But if you look at day by day as we go down, you see it's highly irregular. So it turned out she had a pineal tumor, brain tumor, which we found on MRI. So this is an extraordinary case, but it illustrates that sometimes irregularity in sleep may have a strong medical basis for it. This is a 2-year-old with severe sleep maintenance insomnia, awakens between 1 and 5 a.m. and is monstrous in behavior. very strong, throws things, breaks things, and is extremely disruptive to the family. And when I saw her, I was referred her from a child psychiatrist. She was on a fairly high dose of clonidine and a high dose of trazodone to no avail. And to give you a sense as to how disruptive this is for a family with 2 other healthy children and a father who works outside of the home, very nice family, this is what they had to do. They went to Pets R Us, got the largest cage they could, made it as attractive as possible for her, and used that. Now, we ended up with medication therapy to able to stabilize her sleep, but that's where she slept until then. Here's a 7-year-old who has restless sleep and nocturnal leg pains. She ended up having restless leg syndrome. She'll tell her story.
When your legs were bothering you, what did it feel like?
Let me think. Well, when they were bothering me, they would kick up and down really fast until they got too tired to do that. And then they just stopped like that. And then Mom would do this massage. She does that for my leg, but sometimes it still doesn't help.
What did your legs feel like? Did it feel like you needed to move them? Did it feel like your legs? Yes?
Yeah, I need to move them.
What would happen if you didn't move them?
I don't know, they collect too much energy, and eventually I'd have to move them.
Otherwise, what would happen if you didn't move them?
They collect too much energy, and I don't know what would happen next, because I don't really know what happened next, because I always have to let them move.
So she was treated with medication appropriate for restless leg syndrome, which included iron supplementation and gabapentin, and did very well. Here is another patient, a 2-year-old with severe impulsiveness, violence against his parents or anyone who's around, and major issues with insomnia. So it's very disruptive to the family. But I will tell you, the apple doesn't fall far from the tree in this particular case. The father is very impulsive, as was the mother. Both were diagnosed with ADHD, one with Tourette syndrome and one with a conduct disorder. They had few resources. The 2-year-old was referred to me on a pretty high dose of Seroquel and clonidine. And she did punch me in the face when I was examining her and kicked her father in the groin while I was taking the history. And this apparently was not all that unusual. I don't have a happy ending because the parents never came back for follow-up. But this is an example of what can happen. So genetic and family factors prevented behavioral interventional success. So here's the last case. This is a 4-year-old with an inborn error of metabolism, severe hypotonia, very restless sleep, frequent waking, and difficulty in transitioning from sleep to wakefulness. This was a progressive neurological issue, and the child was extremely disruptive to the family. And oh, I'm sorry, let me back up. This one wasn't as disruptive as I led to believe, but he was very restless. So this will be his sleep study. And what we will see is that he has movements. If I speed this up, you'll see this a little bit more. But these go on throughout the entire night. often involving his legs in full position changes. Okay, so I think you can appreciate that. And he did well with gabapentin. Let's see. Oh, and last one. Sorry, I've got to skip through this. Here we go. This is the one who has a degenerative neurological condition and would scream during the night, frequent myoclonic jerks during the day. And here's the medications that the child came with: Transine in a pretty high dose, so it's related to Klonopin, and clonidine in a very high dose for age. And we ended up finding that on that drug combination, the child did best. And we would, as we changed the medication, we do polysomnography to assure safety. So this is the last polysomnogram, and the child had excellent sleep consolidation, which was amazing for the family. And the child survived an additional year before succumbing to his underlying condition. So here is the Serenity prayer. We can't always have a grand slam, even if we're Ty Cobb or Babe Ruth or whoever, but we can be reasonable and we can be helpful, and we just need to have prudence in our action. So thank you very much, and that's the end of the presentation.